Hey SRNAs, my name is Sean with the Loma Linda University School of Nursing, Nurse Anesthesia concentration. Today, we'll be walking through the steps of an appropriate setup in the operating room to prepare for a general anesthetic induction. We will begin by showing you how to prepare the room, how to get the patient situated, managing the induction sequence, and ending with direct laryngoscopy and airway securement. Before we begin, I want to say a few words about what we are trying to accomplish with this video. As you will all quickly realize in the clinical setting, anesthesia is a specialty where similar results can be achieved through different approaches. And as a result, you will see a wide range in preferences, methods, and overall style among anesthesia providers. What we are doing here is providing a thorough, evidence-backed method of general anesthesia induction that you can all reference as you practice in the simulation lab and get ready for the first day in the operating room. With all of that being said, let's get started.
We'll be using MSMAIDS. The first M stands for machine check. After the full machine test is completed, we also want to check for an alternate source of oxygen and ventilation. An ambu bag will often be hanging on the side of the anesthesia machine or by the anesthesia med cart. The S stands for suction. Ensure that there is sufficient suction through the vacuum and that the yonker and all other connection points are secured firmly. Many anesthesia providers will place the yonker underneath the patient's pillow so that it's within easy reach during direct laryngoscopy. It's also prudent to have an endotracheal suction catheter available for intraoperative use as well. The next M stands for monitors. For any general anesthetic, ASA standards dictate that a pulse oximeter, blood pressure cuff, EKG leads, temperature probe, and nerve stimulator must be utilized in order for a safe anesthetic to occur. Ensure that these devices are all functioning properly and organized in a way to where they can be accessed easily once the patient is in the room. The next letter is A and involves every device for the airway. We want to have a mask available. It's helpful to have 2 strips of tape on the mask for when we tape the eyes closed. An appropriately sized OPA should also be within easy reach in order to ventilate a patient more easily. A laryngoscope and blade will be necessary for direct laryngoscopy. Make sure that you have a MAC blade size 3 or 4, depending on the patient's size, and Miller blade size 2 or 3. Having multiple blade options allows for a quick change in airway manipulation strategy. Next, we will need an endotracheal tube. Tube selection will depend on the size of the patient, but most commonly, you will be selecting a 7, 7.5, or 8. After we have our tube selected, we must make sure that the balloon at the distal end holds air. Once balloon integrity is confirmed, deflate the balloon and make sure that you have the 10 ml syringe close by the tube so that you can use it to inflate later. Next, inserting an intubating stylet will add rigidity to the endotracheal tube and make it easier to aim once in the airway. A common preference among providers is shaping the tube into a hockey stick shape so that the distal end can be aimed up if the airway ends up being slightly anterior. In addition to the primary airway, it is also prudent to have an appropriately sized LMA close by. The LMA has proven to be a valuable part within the difficult airway algorithm and can be a life-saving measure in a can't intubate, can't ventilate scenario. Lastly, make sure that you have a bougie available for those situations with anterior airways that cannot be visualized with the standard direct laryngoscopy approach. The I stands for intravenous access. It will be important to always have supplies available to replace or add another IV. It's also important to know that you have blood tubing available in the event blood is needed. D stands for drugs. The following is a list of medications and their respective concentrations that need to be easily accessible. These include both the emergency and induction medications. Our last letter in the MSMAIDS mnemonic is the final S, which includes any special equipment that we plan on using. This can include an arterial line setup, biz monitor, fluid warmer, bear hugger, glidoscope, and anything else necessary for the procedure. Now that our operating room is set up and ready for the patient, we can go to the preoperative area to introduce ourselves and interview the patient. This is our time to review prior medical records, conduct our preoperative interview, answer any questions the patient may have, and to finalize the anesthetic plan. Once consent for the anesthetic is obtained, a bedside timeout is completed with the patient, anesthesia provider, and OR nurse. Once completed, it is time to get the patient to the operating room. If you are planning on giving an anxiolytic medication to the patient, now would be an appropriate time to do so. Once the patient is in the operating room, you will help transfer the patient onto the actual OR table. Appropriately position them so that their head is toward the top of the table and their chin is up to ensure that the oropharyngeal and laryngeal axes are aligned. Lastly, you'll want to make sure that the operating room table height is raised to your comfort level, as you will be the one masking and placing the airway. Once patient position and bed height are established, it is then time to place all of the appropriate monitors. This will include the pulse oximeter first. For expedience, many providers then place the blood pressure cuff, and while blood pressure is being obtained, they place the 5 leads for the electrocardiogram. We will obtain baseline vital signs and pre-oxygenate. Adequate pre-oxygenation involves at least one of the following: 100% FiO2 for 3 minutes, 4 vital capacity breaths, and an end tidal O2 of 90% or greater. Once pre-oxygenation and baseline vital signs are noted, it is time to begin the induction sequence. For general anesthesia with an endotracheal tube, we begin to administer medications in the following order and dosage: fentanyl, 1 to 3 micrograms per kilogram, lidocaine, 1 to 1.5 milligrams per kilogram, and propofol, 1.5 to 2.5 milligrams per kilogram. To check for consciousness, call out the patient's name. If there is no response, check the eyelids for the lash reflex. With no response, tape the eyes closed with the tape from the mask and begin to ventilate. To counteract propofol's quick redistribution time, many providers will turn on an anesthetic gas while they are ventilating the patient to ensure adequate anesthetic depth. You can always use an oropharyngeal airway to help facilitate your ventilatory efforts. While ventilating, we are assessing for adequate chest rise, misting in the face mask, an adequate end tidal CO2 waveform, and adequate tidal volumes. All are indicators of the ability to ventilate. Once the ability to ventilate is established, it is time to paralyze the patient. Administer rocuronium 0.6 milligrams per kilogram and then resume ventilation. Many anesthesia machines have a timer button on the screen that you can press after rocuronium has been given. Continue to ventilate the patient with the anesthetic gas while waiting for the 90 seconds it takes for the rocuronium to take effect. It is now time for direct laryngoscopy. Turn off the anesthetic gas, remove the mask and oral airway, and gently extend the neck. Some providers scissor the jaw open by touching the fingers to the molars. Others prefer to cradle the occiput and allow the mandible to open passively. Whichever method is utilized, just ensure that there is adequate mouth opening. When placing the laryngoscope into the patient's mouth, focus on keeping your wrist in a fixed position, your elbow in, and imagine your wrist moving toward the opposite end of the ceiling. Hold the ET tube toward the distal end and insert it into the larynx at the 3 o'clock position. Once you have successfully passed the vocal cords, remove the stylet. The ET tube should be advanced approximately 2 centimeters past the vocal cords. The cuff of the tube is then inflated to the appropriate 25 to 30 centimeters of water. This provider did not scissor the mouth and contaminate their glove. However, if that mouth opening method was utilized, the dirty glove would be removed before touching the anesthesia machine to prevent contamination. We will use the mnemonic SMELL to confirm a proper tube placement: S for seeing chest rise, M for misting in the tube, E for an end tidal CO2 waveform. The first L stands for bilateral breath sounds, listening on the lateral side of the chest towards the axilla. The last L stands for lack of audible gastric sounds. With tube placement verified, we will do our left to right check and securing of the tube. While holding the tube with your left hand, use your right hand to turn on the volatile anesthetic, adjust your flow and gas mixture, adjust your ventilator settings, flip the patient onto the ventilator, and recycle the blood pressure and assess the patient's current vital signs. Once everything on the ventilator and monitor is considered and adjusted accordingly, it is time to secure the tube. Often the ET tube is taped on the right side and situated within the paraglossal groove, which is between the molars and the lateral aspect of the tongue. Start the tape on the lower end of the mandible on the left side. Make a loop around the tube, covering the number that you want the tube to remain at. Then continue to the other side of the mandible. it is prudent to lay down one more strip of tape over the initial piece for good measure. Congratulations, you have successfully anesthetized a patient, secured their airway, and connected them to the ventilator for a general anesthetic. Our job doesn't end here, though. This will be a busy time when everyone in the operating room is preparing for the procedure. What you are getting ready will vary depending on the surgery, but consistently, a few things that you will likely need to do include placing a temperature probe, placing a cocoon, bear hugger, or other passive warming device, and administering the antibiotic and antiemetic medications. Many things will be happening at once, but you must always be mindful of what is happening to the patient. Are they hypotensive from the induction medications? Are they tachycardic from the direct laryngoscopy? Is their anesthetic depth appropriate? All of these must be considered and treated promptly.
Excellent job, everyone. If you keep practicing this preparation and flow, you'll be better prepared for the first day in the operating room. When we're new to something, it is easy to become very task-oriented, but remember, a good anesthesia provider stays vigilant and can identify a problem early on so that a quick intervention can be implemented. So stay focused on the patient, keep your head on a swivel, and if a situation arises, be ready to communicate that with the team and act according to your training. Good luck in the simulation lab, everyone, and we'll see you next time.